Hi, everyone. This is a video edition of the SCCM podcast series. I'm Dr. Ludwig Lin, one of the podcast editors, and we have the privilege today of speaking with Barbara McLean, MNRN, CCNSBC, NPBC, CCRN, FCCM. Ms. McLean is a critical care clinical specialist at Grady Memorial Hospital in Atlanta, Georgia. And I'm so happy that we get to glean from her experience, her knowledge, and that of her team. I wanted to ask you about your thoughts about what you're seeing on a daily basis at the bedside. What's confronting your patients and what's confronting your teams?
So what's confronting my patients, first of all, is, and I think many people echo this, and anybody who stays at the bedside for any length of time is very aware of this, is this very rapid deterioration. That 2 hours ago, you had a nasal cannula, you seemed okay, but you have a rapid acceleration in your respiratory rate, typically around 40 to 50 times a minute. As that occurs, you have limited time to exhale your CO2, so you plunge into respiratory acidosis, and you're also in metabolic acidosis. So now your pH is 7.01. Now you've lost the ability to respond to your vasopressors, and there's just a rapid deterioration. If we're lucky, we've already got you on CRT. That can help us a little bit with your metabolic acidosis. But of course, CRT by rights is a slower process, so we don't see that that actually activate a decrease in the metabolic acid, particularly the hydrogen ion, in order to improve your pH that rapidly. And it is a very rapid process. So frequently, as that's happening, you don't really have much time to think about, can I get the family on the phone? Can I put the phone next to my patient's ear? Can I actually use an iPad so that the family can FaceTime so they can understand what's happening? We don't really have much time for that. It happens really quickly. So I think one of the things we always have to talk about with our teams, and we don't have an absolute requirement, some places do, of what we're going to do, but we do have a discussion with the team. How are we going to respond if this patient deteriorates and has a cardiac arrest? What's our response going to be? Is it going to be, none of it is going to be full code. It's always going to be limited in terms of persons, but how many rounds of CPR are we doing? How many rounds of epi are we doing? What's our end process? Have we talked with the family? Does the family know how dire this is? And hopefully that's already happened. We are feeling like we're losing our humanity in this because it's just bed to bed to bed, profound critical illness and death all around us, all the time, much more so than in our normal day. Many people have reported, we haven't had quite this level, but many people have reported 5, 6, 7 deaths a day. That's a lot. That's a lot. And we're talking about one unit. We're not even talking about everywhere. It's a lot. And our staff is, they are in urgent need of support and love and kindness and prayer and whatever else is going to help them. But our patients are completely alone and their families aren't with them. So we're trying really hard to reach out to them, to be with them as they pass, to be with them in these moments of struggle and strife. And we're trying very hard to connect families in whatever way we can.